When first getting hands-on experience with ultrasound, most beginners go through the same inner struggle. As they move the probe across the patient's body, they cannot help repeatedly asking themselves, "Did I miss this view? Was that area scanned thoroughly enough just now?" When looking at the images on the screen, even though they have learned the relevant theory, they hesitate to make a firm judgment, afraid of misdiagnosing a common condition or overlooking a rare one. When encountering complex cases, such as liver cirrhosis, or patients with prosthetic heart valves, the uncertainty intensifies. They may feel completely at a loss as to whether their examination can provide any meaningful reference for clinical decision making. This kind of anxiety, this feeling of not being confident, is not a sign of insufficient ability. It is an inevitable stage in the growth of every beginner. At its core, it stems from uncertainty about three things: whether the scan was comprehensive, whether the interpretation is accurate, and what ultrasound can realistically achieve. Frequent reasons behind the feeling of not being confident. First, an experienced scanning technique, making it difficult to ensure a complete examination. When ultrasound beginners operate the probe, they often lack pose control and technical proficiency. Sometimes, the probe angle is not adjusted properly, causing anatomic planes to be missed. Other times, the probe is moved too quickly and suspicious areas are not examined in sufficient detail. In some cases, the amount of pressure applied is inappropriate, affecting tissue image quality. For example, during echocardiography, insufficient poppet may prevent clear visualization of the full morphology of the aortic valve. During liver ultrasound, beginners may easily overlook the diaphragmaledon of the right lobe or the levo segment of the left lobe. As a result, they may be unsure whether the entire region has truly been scanned. This lack of technical proficiency directly leads to self-doubt about whether the scan was complete, and becomes the primary source of that persistent feeling of not being confident. Second, fragmented knowledge and limited diagnostic discrimination. For ultrasound beginners, understanding of diseases in different anatomical regions often remains at the level of scatter memorization. A complete logical chain from anatomical region to disease category to sonographic features has not yet been formed. The core problem is a lack of systematic awareness of all the conditions that may occur in a given region. They may not clearly recognize the typical presentations of common diseases. They may be unfamiliar with the key features of less common conditions, and they are often unable to accurately distinguish the sonographic differences between similar pathologies. For example, when evaluating valvular heart disease, facing findings such as valve thickening or regurgitation, it can be difficult to determine whether the condition is aortic stenosis, degenerative valve of disease, or congenital valve dysplasia. During level ultrasound, the distinguishing features between hepatomegaoma, hepatocellular carcinoma, and hepatoadenoma may remain unclear. These gaps in knowledge, leaf diagnoses would add a clear foundation, making beginners naturally hesitant to draw definitive conclusions. Third, word cognitive boundaries. Following in today's powerful misconception, many ultrasound beginners assume that ultrasound can evaluate every possible condition, yet they lack a clear understanding of its problem scope and limitations. Ultrasound has obvious strengths, but there are inherent limitations that cannot be overcome. For example, when assessing prosthetic heart valves, transthoracic ultrasound can be limited by the rib cage and lung interference, making it difficult to clearly visualize valve leaflets. Even transcervical ultrasound was superior, may not provide precise evaluation for some atypical lesions. Similarly, small liver lesions and severe sclerosis may be missed on ultrasound, even when MR has already detected them due to heterogeneous layer print China. Other regions, such as the lungs and intestines, are heavily affected by gas, further limiting ultrasound assessment. This lack of clarity about what ultrasound can and cannot do leads beginners to doubt themselves when findings are inconclusive, wondering if they simply did something wrong. 3 key directions to build confidence in ultrasound diagnosis. 1. Refine scanning skills from standardization to muscle memory. First, gain a solid understanding of ultrasound imaging principles. Understand how ultrasound waves propagate and learn how to avoid obstacles such as ribs and lung air. Improve image quality by adjusting patient positioning. For example, use the left lateral tibialis position for cardiac examinations. Uninstruct deep inspiration or breath holding during lower scans. At the same time, optimize probe angle and control the amount of pressure to reduce interference and significantly enhance imaging quality. Follow a fixed scanning protocol to avoid missing any structures. For abdominal ultrasound, scan in a structured order: liver, gallbladder, pancreas, spleen, both kidneys, ureters, and bladder. For cardiac ultrasound, strictly cover all standard views: peristernal, apical, subcostal, and suprastenal windows. This helps establish consistent and standardized scanning habits. Increase simulation training and hands-on clinical practice. Focus on our string probe movements, including sliding, rotation, and tilting. Continuously mosh gunning planes with anatomic odd laces. Record your own scanning sessions, compare them with demonstrations from experienced instructors, and correct technical deviations in a targeted way. Practice repeatedly until you can locate Africa's standard view accurately and efficiently. Second, building systematic knowledge from fragmented memory to logical integration. Study by anatomical regions. For each region, systematically review all possible diseases. Take liver ultrasound as an example. You should not only recognize common conditions such as cirrhosis, hepatocellular carcinoma, and hemangioma, but also understand less common diseases, including liver abscess, hepatic adenoma, and metastatic tumors. Clarify the key distinguishing features of each condition. Create your own personal case database. Organize typical and challenging clinical cases. For each case, document imaging features, diagnostic reason, final pathology results, and causes of missed or incorrect diagnoses. Review these cases regularly. Strengthen the connection between disease, ultrasound appearance, and differential points. Over time, this builds pattern recognition thinking. Rely on authoritative textbooks and clinical guidelines. Study standardized ultrasound protocols and clinical pathways. This ensures accuracy and systematic understanding and helps avoid diagnostic errors caused by fragmented information. Third, defining the boundaries of ultrasound. From blind confidence to rational understanding. For each anatomical region, clearly review the strengths and limitations of ultrasound. The fund is appropriate scope of use. For example, ultrasound has a high detection rate for small lesions in the femoral and breast. It is convenient to perform and involves an irradiation. However, its evaluation is limited. In deep tissues or areas with significant gas interference, such as the lungs and intestines, ultrasound has clear advantages in diagnosing superficial vascular lesions. What for intraluminal vessels, its accuracy is inferior to CTA or MRI. Always remember, ultrasound is only one diagnostic tool among many. Do not expect ultrasound to solve every clinical problem. When findings cannot be clearly defined by ultrasound, such as lavin lesions in the baguana cirrhosis or complex valvular heart disease, actively recommend combining other imaging modalities, including CT, MRI, or transesophageal echocardiography. This creates a complementary diagnostic strategy. Understand the strengths of other imaging techniques. MRI offers high resolution for deep soft tissues. CT clearly demonstrates calcifications in bony structures. PET is more sensitive for detecting tumor metastasis. When ultrasound evaluation is limited, being able to accurately recommend additional imaging tests not only improves diagnostic efficiency, but also significantly reduces psychological pressure on the examiner. Beginner growth confidence is built through accumulation and understanding. Focus on beginners. The feeling of not being confident is, at its core, a process of exploring professional competence and cognitive boundaries. There is no need to rush the process when there is no need to doubt yourself because of temporary uncertainty. Proficiency in scanning technique is built through repeated hands-on practice. A solid knowledge framework is formed through continuous learning and accumulation, and a clear understanding of the boundaries of ultrasound can only be deepened through real clinical cases. Every standardized scan, every case review, and every structure review of knowledge adds to your confidence? When scanning workflows become muscle memory? When does this differentiation follows a clear logical path? And when the strengths and limitations of ultrasound are fully understood, the anxiety of missing a diagnosis or making a mistake naturally fades away. What replaces it is calmness, grounded in professional competence. It is rational judgment, knowing how to use diagnostic tools appropriately. And ultimately, it is becoming a reliable support for clinical decision-making. As an ultrasound physician, confidence in ultrasound diagnosis has never been about being all-powerful. It comes from professional mastery, knowing your capabilities, and knowing your limits, knowing how to scan precisely, knowing how to differentiate scientifically, knowing how to integrate complementary modalities wisely. This is the core path by which ultrasound beginners grow into competent ultrasound clinicians.